talk in IVUS for complex PCI, secret pearls from expert.
I think so. This is the last talk of the session. This is a really great session. So IVUS for complex PCI, secret parts from the expert, like these people are sitting. So I have no conflict of disclosure. So benefit of the IVUS guided PCI, what are that? That is the secret pearls, late main disease, bifurcation, diffuse long lesion, calcified lesion, chronic total occlusion, and the chronic kidney disease. These are the secret pearls. Why? Let us see some of the slide. So if we go to the ADAPT DS sub-study, we can see that definite and probable stent thrombosis is lower if we do the IVUS than if we don't do the IVUS. And the MI is less frequent if we use the IVUS, and MI is more if we don't do the IVUS. So this strategy definitely shows that this is the beneficial by using the IVUS. And main compare registry, 3 years mortality. This is the PARC group. You can see that the angiographic guidance and IVUS guidance, definitely the red bar is the IVUS guidance. It is significantly, the cumulative mortality is lower in the IVUS group than angiographic group. And impact of the IVUS guidance at 3 years clinical outcome, that is the Korean multicenter registry, you also see that the cumulative incidence of death and MI is significantly lower in the IVUS guidance than angiographic guidance. And what are the recommendation in 2024 ESC and the guideline for myocardial revascularization? You can see that IVUS in selected patient to optimize stent implantation. The term is a selected patient, not all the patient. Still, it is in 2014, it is class 2A and level of evidence is B. Clinical use of the IVUS in 2024, IVUS uses during PCI improve the clinical outcome. Let us see some of the trial. Chronic total occlusion, definitely the primary point is significantly, that is cardiac death, MI and TVR is significantly lower in the IVUS group. Diffuse long lesion, you can see that it is also favored if we do the IVUS. So we can come to a conclusion that chronic total occlusion and the diffuse disease IVUS is superior in the clinical outcome. And meta-analysis, you can see that most of the trial, in big trial, is in favor of the IVUS guidance than angiographic guidance. Still, there is some dark zone is remain there, some of the trial. And IVUS expel randomized trial, it is also shown that it is significantly lower in the IVUS group than angiographic guidance. And how IVUS information influenced the procedure from ADAPT to DS registry, you can see that the change in strategy, when you think doing something, length of the stent or length of the balloon or or NC balloon or for post dilatation, 74% you have to change the strategy if you don't use the IVUS. So IVUS may be beneficial and definitely beneficial in this subset of the group. And 2018 European expert consciousness document demonstrated that IVUS guidance and optimization, the long lesion and chronic total lesion, they are not included, they are not demonstrated that in simple lesion, type A lesion, IVUS is superior. But they demonstrate that it is long lesion and chronic total occlusion. And 2018, the ESC guideline again demonstrate that IVUS OCT should be considered in a selected patient to optimize the stent implantation. That is class 2A and B. It is not class 2A. And if we consider the changing of the recommendation, it is the 2014 and 2018, it will be the same. I don't know what will be the recommendation coming in 2025, that I don't know. But still, it is remain the same, that is class 2A indication. I will share one of my case. You can see that this is the patient having a bifurcation lesion with LED lesion, and this is effort angina, ETT positive. And we have done the IVUS, both LED and the diagonal. We exact sizing of the vessel, and we have done the stenting crossover, the diagonal, and also the DCB in the side branch. This is the kissing dilatation. This is the final result. So final result is very good. So in the case of bifurcation lesion, and if you wanted to do DCB in the side branch, IVUS may be the good option and good choice. And this is another case. This patient was admitted with pneumonia, septicemia, heart failure, kidney disease, and also the non-STEMI. So this is a difficult scenario. We have done this case with multidisciplinary approach. And when we done the angiogram, you can see that the RCA, there is a two lesion, one is proximal and one is the distal. And in the LED, there is a diffuse disease. So if you want to fix up both of these vessels, maybe both of the vessels is acceptable result of the IVUS, but for my demonstration, we have done the IVUS only in the diffuse disease, calcified vessel, and on the RCA, this is not a calcified, so we have done the without IVUS. Let us see the outcome in the IVUS in the LED. You can see that there is a huge calcium in the ostium and also the proximal. So here we have used the IVL. IVL is cracked the lesion, and we have stenting both the LED and the RCA. In the distal RCA, we have done a DCB, and proximal RCA, we have put the stent. And this is the IVUS result, final result of the LED. And on the right side, we have done the DCB in the distal segment, and proximal segment is the stent implant stent. And this is the final result of the IVUS. This is the final result of the LED with IVUS guidance. This is the lesion which was not IVUS used. Why I have present this case? If you have deal like this lesion, you can tackle the lesion without doing the IVUS. But if you want to do the such kind of lesion, you must use the IVUS. If you have no IVUS, send the patient to the other places. So thank you for patient hearing.